Welcome to our 7th Asian Pediatric Pulmonology Society Grand Round. My name is Arunwan Kritipan. I am the president of the Asian Pediatric Pulmonology Society as well as the Thai Society of Pediatric Respiratory and Critical Care Medicine. The main aim of the Grand Round activity, which we set up every 2 months, is to promote the interaction and discussion among pediatric pulmonologists from Asian countries. This time, we have Philippines, India, and Thai as our distinguished speakers. The audience will then learn from the experts who may have different approach, different practice, and different technology available. So on behalf of the Asian Pediatric Pediatric Pulmonology Society, I would like to thank Dr. Anna Marie Putulin, the president of the Philippine Academy of Pediatric Pulmonologists, to co-host this event. Today, it is our great opportunity to have Dr. Neptali Ordonez, the immediate past president of Philippines Academy of Pediatric Pulmonologists, acting as our moderator today. So please welcome Dr. Neptali Ordonez.
Thank you very much, Professor Arunwan. Tonight, we will explore the importance of a holistic and systematic approach on evaluation of respiratory symptoms in children, emphasizing the need to consider pulmonary etiologies to avoid delayed diagnosis and improve outcomes. And of course, by recognizing the intricate interplay of organ systems in pediatric patients, we can refine our diagnostic strategies and deliver comprehensive care. Good evening, everyone, dear doctors from all over Asia Pacific. Let me introduce to you our panelists for tonight. First and foremost, we have Associate Professor Kanokpan Ruangnapa. Associate Professor Kanokpan Ruangnapa is a pediatric pulmonologist and a dedicated faculty member at the Faculty of Medicine, Prince of Songkla University in Songkla, Thailand. She holds a Doctor of Medicine degree from Chulalongkorn University in Bangkok and completed her pediatric residency at the Songkla Nagarind Hospital, Prince of Songkla University. She had her pediatric pulmonary fellowship at King Chulalongkorn Memorial Hospital in Bangkok and research fellowship at the Asthma Center of Cincinnati Children's Hospital and Medical Center in Ohio, USA. Our second panelist is Dr. Maria Dulce Requironsi. She is the chief of the section of Pediatric Pulmonology and Critical Care Medicine at the Philippine Heart Center, where she leads with excellence and dedication. She also serves as the chair of the PAPP, Pulmonary Hypertension Task Force, reflecting her commitment to advancing care for children with complex respiratory and cardiovascular conditions. Our third panelist is Dr. Rosalinda Estrella. She is a highly accomplished specialist in mammography, CVS interventional, and general ultrasound with advanced training from the prestigious Thomas Jefferson Hospital in Pennsylvania, USA. She currently serves as the diagnostics section head at the Philippine Heart Center and is also affiliated with St. Luke's Medical Center, Global City, and United Doctors Medical Center. And of course, our last but not the least panelist is Professor Sushil Kabra. He has completed his medical education at SMS Medical College and Hospital in Jaipur, Rajasthan, India. Professor Cabra is a renowned pediatric pulmonologist and has been serving as a consultant and professor of pediatrics at the All India Institute of Medical Sciences in New Delhi, India. And he has held the position of assistant professor of pediatrics at the SMT NHL Municipal Medical College in Ahmedabad, Gujarat, India. And with decades of experience in pediatric pulmonology and a commitment to advancing child health, Professor Cabra is a respected leader in his field, and we are privileged to have him share his expertise with us tonight. So, to be our presenter for this evening, let me call on from the Philippines, Dr. Tricia Vera Paler. She is a senior pediatric pulmonology fellow at the Philippine Heart Center, Quezon City. She had her pediatric residency from Chonghua Hospital in Cebu, Philippines, and the Doctor of Medicine from the Cebu Institute of Medicine. So, Dr. Tricia Vera Paler, you can now start your presentation.
Okay na. Good evening. Good evening, doctors. Our case tonight is on patient JM, a 6-year-old male Filipino from Rizal, referred by the Pediatric Cardiology Service to Pediatric Pulmonary Service due to history of loss of consciousness associated with elevated mean pulmonary arterial pressure upon 2D echocardiogram. For the history of present illness, the patient was apparently well until 11 months prior to admission, when he had an episode of loss of consciousness while walking from home to school, lasting for approximately 3 minutes, and there were no other associated symptoms at this point. A month after, there was recurrence of loss of consciousness, now associated with easy fatigability and occasional chest heaviness. Consult with a general pediatrician was sought. With an initial impression of a possible seizure disorder, he was referred to a pediatric neurologist, and an EEG was requested, which showed normal results. A chest radiograph done showed hypervascular lung fields with cardiomegaly. ECG showed cardiomegaly, and 2D echo was done and showed an elevated mean arterial pressure of 48 millimeters mercury with TR gradient of 66 millimeters mercury, mild mitral regurgitation, and mild pulmonic regurgitation. Initial impression at this point was pulmonary arterial hypertension to consider a congenital heart disease, probably a partial anomalous pulmonary venous return. The patient was advised consult at our institution for further evaluation and management, which was complied on the 9th month of illness. In the interim, the following diagnostic workup were done as outpatient, which includes a chest X-ray, which showed redistribution of pulmonary blood flow, left atrial and biventricular prominence, and a dilated mean pulmonary artery segment. An ECG showed sinus rhythm, right atrial enlargement, biventricular hypertrophy, and right axis deviation. He was then prescribed oral furosemide at 1 milligram per kilo per day. A 2D echo showed elevated mean pulmonary arterial pressure of 55.68 millimeters mercury. TR gradient of 78 millimeters mercury, mild to moderate pulmonic regurgitation, and mild mitral regurgitation consistent with the previous 2D echo done 3 months prior. There was no noted intracardiac defects at this point. A few days prior to admission, the patient was noted to be easily fatigued, unusually stopping during play. There was also recurrence of loss of consciousness lasting for approximately 2 minutes, which prompted consult at cardiology OPD. The patient was admitted for hemodynamic studies, which showed a mean pulmonary artery pressure of 85.5 millimeters mercury, right ventricular diastolic dysfunction with negative vasoreactivity to iloprost nebulization, and pulmonary vascular resistance of 35.8 Wood units, which decreased to 30 post-vasoreactivity to iloprost. The patient was given the following take-home oral medications: furosemide, captopril, and digoxin. The patient was referred to pediatric pulmonology service for further evaluation and management of pulmonary hypertension. Pertinent in the review of systems is the presence of chest pain, easy fatigability, and snoring. The past medical history is non-contributory to the case. For the physical exam, the patient was seen awake, not in respiratory distress, with O2 saturation of 93% at room air. Other vital signs were normal, and the patient's BMI was 13.1 with a Z-score of -2. Pertinent PE finding on the cardiovascular is an adynamic precordium, no precordial bulge, no heaves, and no thrills, with an accentuated P2. Again, we are presented with a 6-year-old male with loss of consciousness, chest pain, easy fatigability, and snoring, with the following objective findings as shown.
Thank you, Dr. Paler. We have just been presented the salient features of the patient's case. Before we move on, we have our first poll question for the evening. So please read through and give back your answer. We have 15 to 20 seconds for you to answer this question. Okay, thank you very much for your participation. It seems like most of our participants have answered 2D echography. So 2D echocardiography. So we probably can now proceed. So probably the next question here is to answer the question of how do we diagnose pulmonary hypertension in children? So to enlighten us more on how to diagnose pulmonary hypertension, let us now welcome our medical expert from Thailand, Associate Professor Kanokpan Ruwangnapa.
Thank you. Can you hear me? Thank you.
Yes, doctor.
Let's to summarize the case again. It looks like he is a 6-year-old boy presented with evidence of pulmonary arterial hypertension by the clinical presentation, the 2D echo finding, and hemodynamic study as well. According to the detailed history taking and presented physical exam, he is an apparently healthy child without structural heart disease. So the next question coming to the pulmonologist is, what is the etiology of pulmonary arterial hypertension? So next slide. Looking for the common cause of the pediatric pulmonary arterial hypertension, we have 4 common groups. The most common group is associated with congenital or structural heart disease, which have not seen in this child. The second common group is in association with lung disease or any condition causing hypoxia. And the rest 2 groups are pulmonary arterial obstruction due to various conditions resulting in thrombophilia or pulmonary thromboembolism. And the last group is systemic disease, such as rheumatologic or autoimmune conditions, as well as genetic disease. So in this case, we have pulmonary arterial hypertension without obvious heart disease. So the pulmonary cause should be excluded initially. Next slide. It looks like our case have no significant pulmonary illness in whose history except mild snoring. This slide shows the cause of chronic or silent pulmonary condition that can associated with pulmonary hypertension. Apart from the detailed history, you can look at the list of conditions in this slide can be differentiated by the proper chest imaging, usually HRCT of chest. I will show the next slide as the stepwise evaluation etiology in children with pulmonary hypertension without cardiac disease. First, to exclude the lung parenchymal disease by the pulmonary function test, HRCT of chest, and as well, don't forget the sleep disorder breathing that cause silent chronic hypoxia. So polysomnography is advocated to routine perform, not depend on clinical suspicion. If all condition is the first group is come to negative, looking for the second condition of chronic thromboembolic phenomenon. And the proper investigation should be ventilation and perfusion scan, RCT angiogram, depending on feasibility of your institute. If they are TE, the next workup should be the blood work done for the find out the connective tissue disease, autoimmune disease, and now the imaging of liver is recommended to exclude that hepatorenal syndrome. However, if all suspected cause could not confirm, don't forget to think about the genetic mutation associated with isolated pulmonary hypertension. The proposed widely accepted gene is BMPR2. And finally, if all investigation mentioned above return negative, so we could diagnose as idiopathic pulmonary arterial hypertension. So this slide is mentioned is the summary of investigation flow for pediatric pulmonary arterial hypertension. Let's move back to the case and see what we found from the bundle of investigation. Dr. Trisha, please.
At this juncture, so working impression at this point is pulmonary hypertension, etiology to be determined, idiopathic versus probable lung disease, chronic right ventricular failure, PVRI functional class 2. For the patient's course, upon referral to pediatric pulmonology service prior to discharge, with an impression of pulmonary hypertension, etiologic determination was leaning towards a probable lung disease. The patient was started on low-dose prednisone at 0.25 mg per kilo per day and sildenafil at 0.5 mg dose every 6 hours. Workup for tuberculosis was also done, which had negative results. High-resolution chest CT scan with contrast, 6-minute walk test as baseline for prognostication, and biomarkers for connective tissue disease were also requested, with advice to follow up once with results as outpatient. The 6-minute walk test showed desaturation episodes to as low as 85% during the procedure. On the 16th month of illness, the patient was readmitted because he was noted to have generalized edema accompanied by non-productive cough and decreasing urine output in the last 7 days upon follow-up at the OPD. He also complained of abdominal pain and fair appetite. On physical exam, he had periorbital edema, a palpable liver edge, 2 centimeters below the right subcostal margin, distended abdomen with a circumference of 50 centimeters, and bipedal edema. At this point, the working impression is right ventricular failure secondary to severe pulmonary hypertension. An arterial blood gas was taken on admission, which showed chronic respiratory alkalosis with mild hypoxemia. Saturations were noted to be labile, with the lowest O2 saturation at 85%, especially during sleep. Oxygen support was given at 1 liter per minute via nasal cannula to maintain saturation of at least 88%. Other workups, such as blood chemistry, urinalysis, and connective tissue biomarkers, were taken, which had unremarkable results.
Okay, I think before we delve further into the patient's course, we have our second poll question for our audience. So this is our question. So what are the diagnostic tests for the diagnosis of pulmonary veno-occlusive disease? So you have the choices there. So it's 15 to 20 seconds time for you to answer. Well, we can see a lot of answers coming in, whether is it pulmonary function test, pulmonary CT angiogram, serologic test, or genetic testing. So we still have some time for you to key in your answer. So there, according to your answers, most of our audience answered pulmonary CT angiogram. Okay, thank you very much for your participation. And so I guess I will now go to our second panelist to give us an overview of the PAPP, pulmonary hypertension clinical pathway used in the diagnosis of pulmonary hypertension and the relationships of pulmonary hypertension and pulmonary veno-occlusive disease with the respective diagnosed test of choice for the condition. Let us now welcome our esteemed medical experts from the Philippines, pediatric pulmonologist Dr. Maria Dulce Requironsi and the radiologist Dr. Rosalinda Estrella.
Yes, good evening, everyone. For this part, my objective is to present the use of the PAPP, pulmonary hypertension clinical pathway, in the diagnosis and management of pulmonary hypertension. The PAPP pulmonary hypertension clinical pathway is a 7-page guide to the diagnosis and management of patients suspected of having pulmonary hypertension. Now, this is the first page, and the first step is to look into the following parameters as written step by step. Pulmonary hypertension manifests with signs and symptoms when right ventricular dysfunction ensues. Signs of peripheral edema, anorexia, nausea, abdominal pain, fatigue, and dyspnea. Signs and symptoms related to peripheral airways obstruction, like the presence of wheezing, imaging with decreased vascularity, and any of the risk factors, the diseases falling under the 5 classifications of pulmonary hypertension, which I will show later. As indicated here, with the presence of any one of these, you can suspect pulmonary hypertension and be directed to go to the next step at number 1. Now, this is the classification which I previously mentioned, which is actually an appendix in the pathway. And the presence of any one of the conditions here is a risk factor for the development of pulmonary hypertension. Screening should be carried out with 2D echocardiography, and it was answered in the poll question. That is step 1. Lucky for us that this was already done when the patient was referred to us. And indeed, the mean pulmonary artery pressure is already elevated at 48 millimeters mercury, the normal of which is just 20 millimeters mercury and below, according to the new guidelines. But with 2D echocardiography, you only get the probability that there is pulmonary hypertension. Now, this is also depending on the value of your mean pulmonary artery pressure, so that a mean pulmonary artery pressure of more than 36 millimeter mercury, just like in the case of our patient, the probability of pulmonary hypertension is therefore high. Now, the next step is right heart catheterization. If the patient is confirmed or the probability for pulmonary hypertension is high. So you proceed as according to the pathway to guide, or to number 2, to guide you through it. And if you suspect pulmonary hypertension secondary to lung disease, because there is a risk for lung disease like the persistence of interstitial infiltrates, like what we have in our patient, you also need to do workup as it is directed in number 4. Even the next step, okay, the hemodynamic studies or the cardiac catheterization had also been done before the patient was referred to us, confirming the elevated mean pulmonary artery pressure of 85.5 millimeters mercury with negative vasoreactivity to iloprost nebulization because the mean pulmonary artery pressure did not go down to the normal level of 20 millimeters mercury. And because a chronic lung disease is the probable etiology that we entertain in this patient in the pathway, we are also directed to go to number 4 in the pathway, which is the screening for pulmonary hypertension secondary to lung disease or hypoxia. For our patient, with the findings on HRCT or the high resolution CT scan, he was worked up for connective tissue disease, and your ANA, double-stranded DNA, and rheumatoid factor were all negative. Biopsy may be contemplated for most of your connective tissue diseases, but quite dangerous and not recommended when you're dealing with pulmonary veno-occlusive disease, which is from the very start one of the major considerations for this patient because of the massive bleeding that will complicate the procedure because the lesions are vascular. Now, Apollo sonography was negative. It was done, but was negative for any sleep-related breathing disorders. Now, this was done to also find out if there are any other factors complicating the patient's condition because he was also a snorer. Now, from the first consult and every follow-up thereafter, patients should be functionally classified. So this is also part of the pathway that we have. Now, this PVRI classification was based on the World Health Organization functional classification of adults, but they came up with what is expected at every age range to be the baseline normal on which kids can be assessed as to improving or deteriorating. Now, our patient was referred to the pulmonary service at functional class 2 and immediately progressed to functional class 3 to 4 in just a few months. Now, this functional classification is an important part of prognostication or prognosticating the patient's outcome, especially mortality, as we will see in the next slide. Now, this is what we use for prognostication, also part of the pathway. Now, with prognostication, there are actually a lot of factors that can be considered as enumerated here, but they actually need not all be done. If there is even just one parameter that falls at any higher risk category, then that would be the risk class for the estimated 1-year mortality. And just like your functional capacity, this can be assessed with every follow-up. Now, this is what we used also to prognosticate our patient's case with the family of the patient. Now, the patient had a low risk for mortality within the first year of diagnosis, but progressively worsened to class 3 to 4. And he died on the 26th month of illness from the first episode of syncope. And that is approximately 10 months from confirming the etiology of the pulmonary hypertension. Now, the bottom of the page on prognosis has this where you put the final diagnosis, classification, functional status, and prognosis. Now, also follows the treatment and follow-up of patients you see with pulmonary hypertension. Okay, so the final diagnosis, as mentioned by Dr. Tricia, is pulmonary arterial hypertension, specifically pulmonary veno-occlusive disease, heritable, because the patient was positive for BMPR2 gene mutation, and the cause of the patient's death was the failing right ventricle, which is the cause of death in every patient with pulmonary hypertension, whatever the etiology is. Okay, now just a little on what pulmonary veno-occlusive disease is. It is a clinical pathologic syndrome, a rare form of pulmonary arterial hypertension that has virtually identical hemodynamic findings as the usual pulmonary artery hypertension. Now, only the characteristic histologic feature of PVOD is what we need to find, which is an obstruction of specifically pulmonary venules and veins by loose fibrous remodeling of the intima that may totally occlude the lumen of the vein. Now, the most consistent parenchymal change is the presence of your interstitial edema. Pulmonary capillary and visceral pleural capillary hydrostatic pressures are elevated in your pulmonary veno-occlusive disease because of this post-capillary obstruction, leading to transudation of fluid into the interstitial and pleural spaces. And as shown here, the post-capillary vessels, mainly the pulmonary venules, are obstructed, and the blood cannot flow into the left side of the circulation, accumulating precapillary and within the pulmonary arterioles, where you have the increased hydrostatic pressures. And this is how interstitial edema formation can be explained in patients with PVOD. There is pulmonary arterial vasodilatation without concomitant pulmonary venodilatation. And the findings of this is strongly suggestive of pulmonary veno-occlusive disease. But of course, we need to do some diagnostic examinations, your high-resolution CT scan, which will show you ground glass opacities bilaterally and mosaic distribution with perivascular areas of hyperattenuation. And this will be further explained by our radiologist expert, Dr. Rosalinda Estrella. Okay, so there's a question here from the chat box with regards to the basis for starting steroid in this child. Actually, when we started the steroid, it was part of the protocol that we use when we treat pulmonary arterial hypertension. The most common cause of pulmonary arterial hypertension in our center is isomengerization, because we're dealing a lot with patients with congenital heart diseases. So since this patient was not yet diagnosed to have PVOD, in which steroid will not be of any use at all, we initially started the patient still on your oral steroids, low dose. We usually give it at 1/4 the dose, or the low dose, 1/4 of the usual dose. That is what we consider as the low dose. Eventually, we had to discontinue even the vasodilators, because both will not have any use at all when the patient has pulmonary veno-occlusive disease.
Okay, so we have one more question in the chat box, and it mentions about the significance of 6-minute walk test. So the 6-minute walk test will measure the patient's functional exercise capacity, and will also be helpful for the baseline prognostication of the patient. So from here on, may we call on our radiologist, Dr. Rosalinda Estrella.
As has already been presented to you, in the chest X-ray, with a moderate to markedly enlarged heart with right-sided chamber prominence, a follow-up CT pulmonary angiogram was done, and showing a dilated main pulmonary artery measuring 2.9 by 2.9 cm, and right and left pulmonary arteries measuring 2.1 and 1.9 cm respectively. In addition to the degree of cardiomegaly is minimal pericardial effusion, as you can see in this slide. Now, for the findings in the lungs, the big arrows that you can see point to the subpleural haziness, mosaic ground glass densities, including interlobular and subpleural septal thickening, while the small arrows point to subpleural tiny nodulations. another slide, which with the big arrows and small arrows pointing to the subpleural haze. This is the same slide, I think. Sorry. At the apices, the same mosaic pattern of glass densities and some tiny subpleural nodulations also noted. Now, I also noted, this is in retrospect na, a few or non-enlarged lymph nodes with the largest measuring 0.52 cm. And I think this all point to PBOD. That is all for the diagnostics. Thank you.
Thank you, Dr. Recurency and Dr. Estrella. So to proceed with the presentation, let us welcome back again our presenter, Dr. Paler.
Okay. So, just a short recap. So, the chest X-ray showed clear lungs at this point, and the heart was markedly enlarged with biatrial and biventricular prominence, and the main pulmonary artery segment was also dilated. And then, as mentioned also earlier, were the HRCT findings of the patient, which had ground glass opacities and mosaic distribution. So 2D echo upon admission showed right ventricular systolic dysfunction, left ventricular ejection fraction of 86%, and an elevated mean pulmonary arterial pressure at 49.6. The patient was referred to a pulmonary vascular specialist who suggested genetic testing, lung biopsy, and pulmonary CT angiogram. He was likewise referred to the service of pediatric hematology, and the patient was started on antithrombotic therapy. At this point, the working diagnosis is pulmonary arterial hypertension with strong consideration of pulmonary veno-occlusive disease, chronic right ventricular failure, PVRI functional class 3. The patient was brought for monthly follow-up at the outpatient department with serial monitoring of INR for adjustment of warfarin dose. During this time, the patient complained of easy fatigability, but with no dyspnea, cough, or fever. On physical examination, he was comfortably tachypneic with O2 saturations ranging between 90 and 92% at room air. There was no periorbital edema. Chest auscultation revealed clear breath sounds, and the abdomen was not distended while there was bipedal edema. On the 20th month of illness, genetic studies were done as outpatient, wherein the pathogenic gene BMPR2 was identified, which is strongly associated with autosomal dominant pulmonary arterial hypertension. So upon advice of the geneticist, screening of the immediate family members was done, and all turned up negative for the mutation. Prognosis and plans were discussed with the family, and they opted to not proceed with lung biopsy. Instead, palliative care was decided upon. On the 26th month since PAH diagnosis, the patient was brought to the emergency room due to shortness of breath. And upon further examination, he had periorbital edema, fine crackles on auscultation, ascites with an abdominal circumference of 72 centimeters, and bipedal edema. O2 saturations were maintained between 90 and 92% on 2 liters per minute oxygen support. The patient was again admitted and ancillary tests were done. Chest X-ray revealed no active parenchymal infiltrates and no pleural effusion. While whole abdominal ultrasound revealed massive ascites, CBC, serum albumin, and bleeding parameters were normal, while serum sodium and potassium were decreased. A repeat bedside 2D echo was done, which showed further decrease in the RV FAC at 24% and LV ejection fractions at 61%. There was also noted pericardial effusion, markedly dilated right atrium and right ventricle. Ultrasound-guided pigtail insertion was done to drain the massive ascites, draining 30 cc of serous fluid. However, on the second hospital day, the patient went into sudden cardiopulmonary arrest. The parents were apprised of the patient's condition, and they eventually signed the DNR waiver. The patient expired thereafter. Cause of death of the patient is chronic right-sided heart failure, with the final diagnosis of pulmonary arterial hypertension class 1, severe pulmonary veno-occlusive disease, positive for BMPR2 mutation, PVRI functional class 4.
Okay. At this juncture, we will have our last poll question for the evening. So let us answer this question. What are the medications that may be given in the management of pulmonary hypertension and pulmonary veno-occlusive disease? So we have our choices and 15 to 20 seconds to answer. Would it be prostanoids, immunomodulators, lung transplantation, or all of the above? Okay, we have more time to answer. There, it seems that most of our audience answered all of the above. Okay, so I guess as of this point, we have already learned of a rare case of a vascular cause of pulmonary hypertension in a child. This leads us to the next question on how do we treat this problem. So to enlighten us on the management of pulmonary hypertension and pulmonary veno-occlusive disease, let us welcome our pediatric pulmonologist, specialist from India, Professor Sushil Kabra. Professor Sushil.
Thank you, Nafsali. So I'll take you through how to manage pulmonary hypertension, pulmonary arterial hypertension, and briefly discuss about the PVOD. So management of pulmonary arterial hypertension in children is very challenging, and the treatment in adult is based on randomized control trials, while in children it is based on small case series and extrapolation from studies done in adult patients. And we can discuss under following heads like general measures, supportive measures, specific measures, heart-lung transplant, and novel therapy. So general measures include control of the underlying illness, like if it is because of the rheumatological disorder, cardiac illness, pulmonary, or hepatic disorders. That is the primary thing that we control that. Children should be encouraged to perform normal daily activity with a symptom limitation, and measures for prevention and treatment of respiratory infection that include general hygiene to reduce infections, immunization for influenza and pneumococcal, and try to avoid having a pyrexia because that will increase the work of breathing, and avoid constipation and excessive cough with symptomatic treatment. So supportive care include if there is a evidence of abnormality in coagulation and fibrinolytic pathways in patients with idiopathic pulmonary arterial hypertension, and these patients are also at increased risk of thromboembolic disease, and in those situations anticoagulation therapy may be beneficial, but in few cases, and it should be considered very carefully, as in the index case it was started by our hematologist. Diuretics are helpful in pulmonary arterial hypertension with fluid overload because of the right ventricular dysfunction, and oxygen therapy is helpful in reduction of the peripheral vascular resistance in PH, and correction of arterial hypoxemia noted in some patients with pulmonary arterial hypertension. And sometimes digoxin may be considered if there is a supraventricular tachyarrhythmia to slow down the ventricular rate. So there are certain targeted therapies. As I said, these are based on some case series and extrapolated from randomized control trials carried out in adults. And the major class of medicines are calcium channel blockers like nifedipine and amlodipine, and they may have a systemic hypotension, pulmonary edema, and right ventricular failure. The other group is prostanoids like ipoprostenol, iloprostrol, or treprostinil, and these are the last one, like treprostinil has not been approved for children, and the other one are based on the some limited experience. Other major group which we generally use is endothelin receptor antagonists, which include bosentan, which is commonly used, and the other newer drugs like sitaxetan and amistriptan, they have not been cleared for use in children. Other for supportive care include nitric oxide inhalation, and that may have some risk of methemoglobinemia. And then lastly, the phosphodiesterase type 5 inhibitors, which include sildenafil, and that is being commonly used, and our index case also received it. Tadalafil is another newer drug, but it has not been approved for use in children. So generally, people are going towards the combination therapy, either stepwise or at an initial stage of starting therapy, but exact combination of drugs, optimum timing, long-term safety and efficacy still require evidence. And in some cases, occasionally atrial septostomy for decompression of the right atrium and ventricular considered as a palliative therapy in children having a idiopathic pulmonary arterial hypertension with recurrent syncope and severe RV failure. Novel therapies, these are listed here, they are not approved for children. And gene therapy, with the understanding of the role of few genes in pathogenesis of PAH, the possible role of stem cell therapy is under trial. So, as it was very evident that heart-lung, most of those who are not responding to treatment, heart-lung transplant is the treatment. And another thing include early identification and treatment of complications like right heart failure, sudden death, which happened in the index case. Prognosis with the evidence, with the advent and use of specific therapy in children, the prognosis has improved dramatically, but remains poor, especially in developing countries. Prognosis is also affected by the type of PH and severity of illness at presentation. Study from Western countries has estimated the 10-year survival rate in children up to 78%, but in other countries it is still very low. So now, as a pediatrician, we are challenged with the management of chronic lung disease. And PH is an important complication of chronic lung disease associated with worse outcome. And management of these is very non-specific, and there is no targeted therapy. Optimizing the treatment of the underlying pulmonary condition contributing the comorbidities, thromboembolic phenomena, sleep disordered breathing, supplemental oxygen, lung transplantation for suitable candidates. And there is a little evidence to support the use of medications that treat pulmonary arterial hypertension, as I had discussed in the previous slide. PS therapies can be harmful in some cases, specifically PVOD, PCH, and obstructive airways disease. And there is an emerging interest using inhaled pulmonary vasodilator therapy in pulmonary hypertension due to lung disease. Next slide. So now we come to the what is the treatment or management of pulmonary veno-occlusive disease, as it happened in the index case. The therapeutic options are limited, and lung transplant remains the only viable cure. Pulmonary vasodilator therapy is tolerated poorly, and in some patients as compared to idiopathic pulmonary arterial hypertension. Initiation of these therapy frequently leads to increased transcapillary pressures and pulmonary edema following pulmonary arterial vasodilatation, and can result in rapid clinical deterioration or death. Immunomodulators, including prednisolone, azathioprine, cyclophosphamide, has been used successfully in patients with sarcoidosis and associated PH, not in a PVOD. Preliminary success with PDGF inhibitor in patients with both PVOD and PH provided early enthusiasm as a new treatment option. Recently published phase 3 trials, open-label extension study of imatinib reported significant risk of adverse event, including subdural hematomas. Next slide. To summarize, the pulmonary hypertension, an important cause of morbidity in children. Management include general measures, as I had discussed, supportive care, optimal management of the cause, and targeted therapy wherever it is indicated. There are no randomized controlled trials in children for targeted therapy. Current recommendations are based on small case series and extrapolated from studies done in adult patients. Pharmacotherapy consists of calcium channel blocking agent, prostanoids, endothelin receptor antagonist, nitric oxide inhalation, phosphodiesterase type 5 inhibitors, and so on. For PVOD, cautious consideration of vasodilators because it may cause worsening. And if unresponsive, as it was in the index case, only thing left is heart-lung transplant. Thank you very much.
Thank you, Professor Cabra, for enlightening us with the different management options for this case. And as we end, we would like, of course, to acknowledge our presenter from the Philippines, Dr. Tricia Vera Paler, together with our esteemed panelists from Thailand, Associate Professor Kanokpan Ruwangnapa, from India, Professor Sushil Cabra, and from the Philippines, Dr. Dulce Requironsi and Dr. Rosalinda Estrella, who tackled perfectly on the vascular cause of a dyspnea in the child. So this is a very rare case, and we hope we have learned a lot from this academic exercise. And to formally close our academic event for this evening, may we now call on Professor Kunling Shen, who is a past APPS president. Professor Kunling Shen.
Thank you so much for everyone. Dear Professor Aruna, sorry for my pronunciation.
Okay.
And also Professor Daniel Wu, and dear council members of APPS, colleagues and friends. It is an honor for me to stand before you today at our seventh grand round, dedicated to explore the complex and often recognized the topics of vascular causes of dyspnea in children. Actually, this year, under the leadership of APPS President Aaron and also the founding president of Daniel Wu, APPS began to have grand round online every 2 months. It was so good. I joined every time. So it is very, very organized and also very good presented, and also very good discussion, a very good introduction of the expert of the aspect of the disease. It is so good. I heard a lot of colleagues said that is so good. But next year we will organize more Chinese doctors to join. So congratulations for all of your effort. Actually, I recall that I'm the president of APPS. I have seen the growth of APPS in the last nearly 15 years. So actually, our Asian have the largest population. So we have the largest numbers of the children. So we have the same culture and same tradition, and also the same gene of Asian. So we have to, so we should, and also we have to unite it and to raise the levels of the diagnosis and the treatment for the children's for the children's pulmonology problem. So I'm sure APPS can provide that kind of a platform for our Asian pediatricians and also Asian pediatric pulmonologists through this kind of annual congress, and also through this kind of grand round, and also research collaboration. So congratulations for the development of APPS in all of your by all of your effort. And I would like to take this opportunity to see Merry Christmas and Happy New Year, because Christmas were coming and the New Year were coming. Thank you so much. We hope that our APPS grow tremendously. Thank you so much.
Thank you, Professor Shen, and Merry Christmas as well. We know that under your guidance, under the leadership of Professor Arunwan, APPS will surely go heights. So, Professor Arunwan, you have announcements?
So I would like to thank all the panelists today that this is a volunteer work. that you spend effort and spend time and you have no incentive at all. So I would like to appreciate your time, that your contribution to give the better knowledge to our Asian pediatrician. So I would like to thank you all for your kind contribution.